Okay, so now let's talk about thrombocytes, also called platelets. Um, these are the cell fragments. They're not a complete cell. These are the fragments of cells that are super important for forming blood clots. So anything involving blood clots, that's what they're doing. Um, they change their shape if they get activated. If they're activated, long fibers come, I shouldn't say fibers, but extensions stick out and they get big, pointy, jagged. That helps them catch the on the edge of a wound. Anyway, but let's go through. So, platelets are fragments of a bigger cell called a megakaryocyte. So megakaryocyte in the bone marrow, and pieces of it break off that we're going to call thrombocytes or platelets. These things are they're going to stain blue with purple granules in the middle. Let's see. They have chemicals that are involved in clotting. I'm talking about serotonin, calcium, enzymes, ADP, adenosine triphosphate. Um, Platelet-derived growth factor. Okay, yeah. So their job is to make a plug that prevents blood from oozing out of a wound, and this happens on uh, that plug may be sufficient. That may be all you need in a smaller vessel. A bigger vessel, we're going to do more things, but we'll talk about that. Anyway, they've got platelets. Platelets are circulating around and they're kept inactive and mobile by nitric oxide. Like I said, if they become active, they change shape, grow big extensions, and then easily get caught on the edges of the wound. Um, anyway, prostacyclin and nitric oxide are keeping them inactive in their inactive shape. And that prostacyclin is made by the endothelial cells lining the blood vessels. We haven't talked about this yet, but the blood vessels, the inner layer, the tunica intima that's in intimate contact with the blood. That's a smooth, slippery layer of endothelial cells, and those are the ones we're talking about. They are releasing prostacyclin to keep the platelets from being active and forming plugs. Anyway, so I told you that another name for platelets is thrombocytes. Well, you remember red blood cells, erythrocytes, making a red blood cell was erythropoiesis. Well, thrombopoiesis would be the making of the platelet. And not surprisingly, the thrombopoiesis is controlled by the chemical thrombopoietin. All right. So a megakaryoblast is going to do mitosis, but not cytokinesis. What we mean is it's going to be dividing up the nucleus, reproducing the nucleus, but it's not breaking off pieces, like not dividing into separate cells. The result is we're going to form a big multi-lobe nucleus cell. Has lots of DNA in it. And it says this megakaryocyte is going to send cytoplasmic projections into the lumen of capillaries, and those projections will break off pieces as platelets. Platelets only last about 10 days. They're not a complete cell, so they don't have all the stuff to do cell repair. You normally have 150 to 400 platelets in a milliliter of blood. Okay. Here is the process of thrombopoiesis, controlled by thrombopoietin. This is the making of the thrombocytes, the platelets. All right, so that's the end of the different formed elements. This table 17.2, you're definitely going to have questions based on this. You definitely need to be able to identify the different types of formed elements when you see them or see diagrams of them. All right. Hemostasis is, remember, stasis, we're trying to maintain constant conditions. Hemo involves blood, so hemostasis, we're trying to keep the blood conditions and the volume normal. That means we're trying to stop the blood from bleeding out when there's a wound. This is going to require clotting factors and substances released by platelets, released by the injured cells in the blood vessel. There are 3 steps in forming a clot, and we're going to go through each one of those. But right there, vascular spasm, platelet plug formation, and coagulation of the blood. All right, if, say we've got an injury, we've injured a blood vessel, and that blood vessel will start with vasoconstriction. What that means is the lumen, the hole in the middle of the blood vessel, it gets narrower, it gets smaller. How is that possible? The middle layer of the blood vessel, the tunica media, is muscle. It's smooth muscle, and it will contract to narrow the blood vessel. Why are we doing this? We're trying to reduce the amount of blood that goes through that vessel. And we're doing that because it's a damaged vessel. We're trying to reduce the amount of blood that tries to go through it and then leaks out. So these vascular spasms, these smooth muscle contractions, are triggered by injury to the muscle, by chemicals from the endothelial cells and platelets, or pain reflexes. This works really well in small blood vessels that were already pretty tiny. Larger ones, it's a lot less effective. Anyway, just by doing the vascular spasm, the vasoconstriction, you can reduce the amount of blood that's being lost, and that will buy you time until you can have other things happen. Now, the second step, platelet plug formation. Let's go back to that pretty picture, okay? So, vascular spasm was smooth muscle contraction to vasoconstrict, to narrow the blood vessel. Smooth muscle in the wall of the blood vessel. What we're about to talk about now is platelet plug formation, okay? So, platelet plug formation, the platelets will stick to collagen fibers that are exposed when the blood vessel is damaged. They haven't talked about this yet, but we'll get to it. The fibers that are being exposed, it might be, I think what they're talking about is fibrinogen being turned into fibrin. We have, that's mildly complicated, but we'll do this. There are, when you're doing blood clotting, there is an enzyme that it's called thrombin. And what thrombin will do is take an inactive form of a protein, inactive form of a fiber that is all wound up tight, and that way it floats through blood vessels really easy, doesn't get caught on things. But that's not the form we need when we're doing blood clots. We're doing blood clots, we want it to get caught on stuff. So you have an enzyme that will change this fiber from its inactive fibrinogen to the active fibrin. It makes it unwind into a long piece that can get caught across the wound easily. Anyway, platelets will stick to collagen exposed in the vessel. Okay, they're talking about the collagen that's part of the basement membrane of the vessel. So when the vessel is damaged, you have in the layers, you have collagen fibers, and they're exposed, and the platelets will stick to that collagen. Now, the smooth endothelium, you can't see any collagen, so platelets will stay in their normal inactive form until they touch collagen, and then they grow the extensions. So, and prostacyclins, nitric oxide from the endothelial cells will also keep things inactive until you damage those endothelial cells, and they don't do that anymore. Von Willebrand factor will stabilize platelet collagen adhesion. Okay, so when it's activated, the platelets will swell, they get spiked and sticky, they have long extensions. Do we have a nice picture of one that's been activated? No, we don't. That's horrible. We should have a photo of one that's activated. So hold on. Okay. Here you can see the difference in let me drag that up a little, an inactive resting thrombocyte or platelet, and the active form with all these huge spikes pew, 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 that have grown out. Whenever it becomes active, it has all these extensions that stick out that help it grab onto things. Here is it's too tiny to be useful. Here's a drawing, illustration showing inactive and active form. They grow extensions that help grab onto the damaged wound, to the collagen, and at the wound site. And fine, good enough. Just want to make sure you that you knew, that you understood what we were reading. Let's get back to the reading. All right, so when activated, platelets swell, they get spiky, they get sticky, they release chemical messengers. ADP, adenosine triphosphate, causes platelets to stick and release their contents. Serotonin, thromboxane A, they enhance the vascular spasm. I mean, that makes it the vasoconstrict even better, and it makes platelets get better at sticking. This is a positive feedback cycle. Plug formation, positive feedback. What we mean by that, if you remember from AP1, we talked about positive and negative feedback. Most things in the body are like keeping your body temperature constant. That's a negative feedback. Oh, I'm a little too hot. Okay, I'll sweat. Oh, I'm a little too cold. Oh, I'll shiver. And you go back and forth. You waver above or below a set point, but you stay real close range right around the thing you want to keep in stasis, thing you want to keep constant. Positive feedback is like birth. What I mean by that is, oh, well, we're having some contractions, and well, the body releases oxytocin, but those cause stronger contractions, which causes more oxytocin, which causes stronger contractions, which causes more oxytocin until the contractions get so strong you push the baby out. That is a positive feedback mechanism. Like, it's building on itself and getting bigger and bigger and stronger. The same thing is happening here with plug formation. Positive feedback cycle. As more platelets stick and spill out their contents, that causes more platelets to stick and spill out their contents. And this platelet plug, that's enough to fix a small vessel, to stop the leakage from a small vessel. Bigger vessels, we're going to have to do more. This is where we're going to break out the prothrombin, thrombin, and the profibrin, fibrin. But we'll get to that. So coagulation, this is step 3. We have to reinforce that plug of platelets. Like, the platelets got spiky, they covered the edge. That's good. You stop the leaking. But you need to form blood clots if you're going to fix a bigger wound. If it's a bigger vessel, bigger hole, you need something to reinforce it. And those are fibers, okay? Those fibers that cross the wound, then you'll have red blood cells getting caught behind them. Kind of like if you've ever been walking along a stream and you see branches across the stream. Of course, if you do, there are going to be all kinds of leaves and trash that get caught as they're washing along. They get caught behind all those branches on the surface. In the same way, if you unwind a bunch of fibers and let them go across the wound, then they're going to capture other things that try to wash through until you have this big clot there. So anyway, when we do clotting, we're taking the blood from a liquid to a gel. Obviously super dangerous. Obviously, we only want to be doing this right at the site of the wound. So the goal here is to take procoagulants, which are plasma proteins, and vitamin K. We're going to use all this to unwind fibers. And what you need to know is the unwinding is done by an enzyme named thrombin. Normally, we don't want thrombin working. We don't want to be making these fibers. So there's an inactive form of thrombin called prothrombin. And in the same way, there are fibers that we call fibrin, but they are normally floating around in the blood in an inactive form and wound up tight, so they can easily slip through vessels and stuff. An inactive form like that is called fibrinogen. So prothrombin can become thrombin. You now have the thrombin enzyme. If that happens, thrombin is the enzyme that will then turn fibrinogen into fibrin. Okay. So coagulation, 3 stages. This is down here. This forms a mesh. It traps the red blood cells and platelets. Oh, why is that? Let's see, going the right direction. There we are. And that forms the clot. So we're through that. Here we are, coagulation. So there are 2 parts. There's 2 different ways we can do this. What we're doing, the intrinsic pathway is clotting that depends strictly on chemicals found in the blood itself, substances found in the blood. Extrinsic pathway, which is faster, it is caused by things outside the blood. Extra means outside. So the extrinsic pathway, that's caused by things that are found, they're not normally found in the blood. And of these 2, they both are doing the same thing. They both are making prothrombin activator, which will turn the prothrombin, the inactive form of the enzyme, into the thrombin, the active form of the enzyme. So they both have the goal of activate the enzyme. Both make the chemical prothrombin activator to activate the enzyme. But the extrinsic is faster. All right. They both are a chemical cascade where one change causes more, causes more, causes more. But it's faster in the extrinsic because you're skipping steps. All right. So the intrinsic pathway, called intrinsic because all the factors are in the blood already. And this is the type of clotting that we have if there are activated platelets, if there's exposed collagen, if there's any charged substance like a container that we extracted blood into, the wall of the chamber could have a charge. Its charges cause the coagulation. The extrinsic pathway, the fast one, these factors are normally outside the blood. Exposure to tissue factor or tissue factor 3. What that means is if you damage the cells in the lining of the vessel, they're releasing tissue factor, and tissue factor is causing the clotting to start. And we already said many times, it's the faster pathway because it's skipping steps. Here's a comparison of the two. Remember, the practical upshot of both is getting down here to make prothrombin activator. Our goal is to make prothrombin activator, which will activate the enzyme thrombin. That means it'll take it from the resting state, the inactive form, prothrombin, and turn it into the active form, thrombin. All right. So prothrombin activator will turn prothrombin into the active enzyme thrombin. Thrombin is then going to take fibrinogen, and turn it into fibrin, a long protein fiber. So it takes the wound up fiber that's like, imagine a long pipe cleaner that you wad up into a little ball. That is your fibrinogen. And what thrombin will do is take it and straighten it out. So you now have a long pipe cleaner, a rod that doesn't go through the blood vessel as easy as when it was all curled up. That is going to get caught on the edges of the wound. All right. So fibrin is what we get when we activate this. So thrombin converts soluble fibrinogen. It's soluble, meaning it dissolves easily because it's wound up into this tight little ball-shaped form. And the thrombin will take that and unwind it into the fibrin. At that point, it doesn't dissolve so well, so it comes out of solution. The fibrin strands are the structural basis of the clot. They are the stuff, the branches. When I compared branches across a stream and everything getting caught behind it, that's what the fibrin is. They're long fibers that will cross the wound and everything gets caught on it. So fibrin causes the plasma to get gel-like and trap the formed elements. Thrombin will activate fibrin stabilizing factor that will hook the fibers together, and that will strengthen the clot, stabilize the clot. And anticoagulant factors that normally dominate the blood to inhibit coagulation. So our blood is full of chemicals normally to stop this from happening. But in the emergency situation that you have wounded, that you have damaged the blood vessel, you've got to stop the bleeding. Remember, this whole process is part of hemostasis, keeping the blood volume constant. How do you do that? You stop the blood from leaking out. All right, so We've got that. We've got that. We've talked about that. Yeah, we're good. Okay. I'm actually, I'll tell you right now, looking at table 17.3, I do want you to know about fibrinogen becoming fibrin. I do want you to know about prothrombin becoming thrombin, and that being the enzyme that turns the fibrinogen into fibrin. Both of those, yes. Know that calcium has to be present to clot properly. Yeah, I'm not going to do anything about factor 5 proaccelerator. Yeah, okay. Looking at this, the factors on table 17.3 that I'll want you to know are 1 through 4, which are fibrinogen, prothrombin. Here, let me do that as you can see my hand. Fibrinogen, prothrombin, tissue factor, calcium. That's it for the top of the table. And then at the bottom, the fibrin stabilizing factor. So I want you to know 5 of the things off of this table. Those are the most important. Okay. So once we have the clot stabilized, we then have to make it stronger. And what'll happen is that the platelets, remember I said, oh, they grow these extensions? Those extensions are made out of actin and myosin, or they have actin and myosin inside of them. And those are the same chemicals that you remember from muscle contraction. So these fibers can then, you can have the spiky looking platelet, thrombocyte. It will pull those fibers back in, will pull those extensions in. It will return to its smaller, less spiky shape. What that does is take the edges of the wound and pull them together. It also, draws, that's where it says draws ruptured blood vessel edges together. It's pulling them together, but it's also squeezing out the blood serum. All the liquid parts are getting squeezed out. The clot is now getting denser and stronger as you squeeze the liquid parts out. So anyway, yay platelets, yay thrombocytes. Okay, and as you are doing that, you are also, why is this not working? Hold on a second. Okay, there we are. So, as this happens, we need to build a new wall. We can't just leave a clot in there. We have to build new blood vessel wall. And platelet-derived growth factor is released by the platelets. So as they're pulling in their extensions, they're also releasing this growth factor. That's going to cause the smooth muscle cells and the fibroblasts to rebuild the outer layers of the blood vessel wall. The fibroblasts, if you think of the outside, the tunica externa, lots of fibrous tissue. Then you have the middle layer of the blood vessel, the tunica media, lots of smooth muscle. Well, we also have the inner layer, that endothelial layer, that tunica intima. That is stimulated by this vascular endothelial growth factor. Anyway, that'll make you grow a nice, new, slippery, smooth lining for the blood to go by. All right, moving on. So, and then the next step after that, you're going to have to break down the fibers of the fibrin. I want you to remember the word lyse means to break. So fibrinolysis means breaking down the fibrin. This is the process where we get rid of the clot after we've repaired the wall. This starts about 2 days after we made the clot, and it will continue for several days until we dissolve that clot. Plasminogen in the blood plasma will be turned into plasmin. Again, when you see O-gen, know that this is the inactive earlier form that can become active. Well, we're going to turn this plasminogen, we're going to make it active, turn into plasmin, and that's an enzyme that will chew on, it'll break down that fibrin, digest the fibrin. Tissue plasminogen factor activator and thrombin will be involved in converting this. That's not as important. I want you to know it is converted. We've got enough chemicals to learn already. I'm not going to do tissue plasminogen activator or by its other name, factor 12 or don't worry about that. Just know that plasminogen becomes plasmin, and plasmin is the enzyme that breaks down the fibers in the clot. All right, so factors limiting clot growth. We've got to stop the clot. We can't just let it go crazy. Positive feedback mechanism. We'd turn all the blood into a big clot. Can't pump that. It can't carry oxygen. It'd kill you. So we have to stop it. So how do we limit clot size? The first one is the blood flows through, it washes away all of those clotting factors. It dilutes the clotting factors, spreads them out so they can't have that effect again and again and again. We also have chemicals released that inhibit the clotting factors. Okay, like clotting factors do their job. Now shut them up. Okay, inhibit them doing their job. Thrombin is restricted to the clot by fibrin threads. And that prevents old clots from getting too big or getting into the bloodstream. We also have chemicals that do the exact opposite. Antithrombin 3 will inactivate unbound thrombin that escapes into the bloodstream. What we're saying is, remember, the whole clot formation depends on prothrombin activator, which will turn prothrombin into thrombin. Thrombin is the enzyme that will activate the fibrin. Well, we don't want it doing that in places away from the wound. So what do? We release chemicals that will take that enzyme. If that enzyme is not at the wound site, is not actively doing what it should be doing, turning fibrinogen into fibrin at the wound, we're gonna break it down. We're gonna denature the enzyme. Antithrombin 3 changes that enzyme, stops it from working. Also, white blood cells, the basophils and the mast cells, they're going to shut down thrombin. They're going to be releasing this antithrombin 3. They'll be releasing this heparin. Those are going to stop the enzyme, shut down the enzyme, deactivate the enzyme. All right, so what do we do to stop undesirable clotting? You have to stop the platelets from sticking. So the smooth endothelium prevents the platelets from sticking. You remember that's releasing nitric oxide. It's releasing, what was the other thing? Let me hold on. Of course, it's going to prostacyclin. That's what I was looking for. Prostacyclin is going to be released from the endothelial cells. So where it says smooth endothelium of blood vessels prevents platelets from clinging. It was on the same slide. Good grief, I should just read down. Nitric oxide and prostacyclin are being released from the endothelial cells, which are, remember, in a layer called the tunica intima. The innermost layer, the one that is in intimate contact with the blood. Vitamin E, quinone, that's vitamin E plus oxygen, is a potent anticoagulant. We have these anticoagulants floating around in the blood. So if we're not right at the site of the wound, we're going to break it down. That's how we stop the clotting from continuing, or try to stop the clotting from continuing further. All right. So there are two types of disorders you could have. Thromboembolic disorders, this is when you make clots and you shouldn't be. And bleeding disorders, this is when you don't make the clots that you should be making. We're about to go through both disorders. And if you have a DIC, disseminated intravascular coagulation, you could have both things going on in different parts of the body, bad. Okay, so basic definitions here. A thrombus is a clot that is in an unbroken blood vessel where we shouldn't have one. It could block circulation, it could cause tissue death. An embolus is what we call it if the clot, the thrombus, breaks free and is floating around. An embolism is if that embolus suddenly sticks and clogs things. So embolus, obstructing a blood vessel, pulmonary embolism, cerebral embolism. Obviously, if you're not delivering blood, you've got tissue dying because it needs oxygen. Bad. So what things could be a risk? Arteriosclerosis, inflammation, slow-flowing blood, or blood stasis from immobility. Got to get up, got to move, got to be active. If you have scarring of the arteries, a lot of times that's that plaque made out of cholesterol. It's spiky, it's rough, and it can snag platelets and rip them open, and then you can have all the things happening just like it was the edge of a blood vessel that was ripped open. The platelets are going to cause more platelets to form, and then you're going to get clots, and it'll be bad. So what can you do about this? If someone's has conditions that might cause this, you could have them take anticoagulants to prevent clotting, make clotting less likely. It could be aspirin. That's an antiprostaglandin. It inhibits one of the precursors, lowers heart attack incidence by 50%, just being on a daily aspirin. Heparin, which right after cardiac care, right after someone was in the hospital for heart problems, you could give them heparin, a chemical that will prevent thrombosis, prevent the clots from forming. Warfarin, in medical trade, we tend to call this Coumadin. Like, oh, I went to the Coumadin clinic, and what they're giving the person is Warfarin. Coumadin is a trade name for Warfarin. It's a direct anticoagulant, reduces stroke in patients who have atrial fib. If you have atrial fib, the heart is not contracting well in the upper portions, the atria. Blood's sitting there, it's pooling. Well, that makes it a risk of clotting. Warfarin can prevent that from happening. The way it works, the way this Coumadin, this warfarin works, is messing with the action of vitamin A. A side issue, warfarin, very strong, very powerful. So much so that in the past, it's been used as a poison for rodents because it will make it easy for them to bleed, and they will fight with each other and then die of internal bleeding. Anyway, so yeah, warfarin, which we call Coumadin. All right, let's talk now about the opposite of forming too many clots. This is when you bleed too much, you don't clot well. Thrombocytopenia. Thrombocytes are platelets, remember, so involving platelets. Cyto, cell or cell fragment. Penia is the suffix we use when there's not enough. So thrombocytopenia, big fancy word, very simple. It says you don't have enough thrombocytes. This can cause little tiny hemorrhages all over. We call this petechia. There's a picture of it right there. All right. This can happen because we've damaged the red bone marrow, maybe with radiation or drugs. We would diagnose the low platelet count as less than 50,000 platelets per microliter. And how do you treat this? You would treat this by transfusing platelets in. So, all right. You could also have this happen because your liver's not working. That means you're not making enough vitamin K. Remember, vitamin K is necessary for clotting. So if you mess with vitamin K, if you say your liver is damaged, or your liver doesn't have enough vitamin K to work, so you're not getting enough vitamin K, or you damage the liver with hepatitis, or you drank too much and damaged the liver with cirrhosis. These liver diseases can stop the liver from making the clotting factors that we need. You could also have trouble making bile. If you do that, then you can't absorb fat or fat soluble vitamins. Those vitamins are A, D, E, and K. So yeah. All right, hemophilia, kind of a horrible name. It means philos, love, hemo, blood. So the love of bleeding. What this is someone just bleeds a lot. They have trouble clotting. This usually is a case of not having clotting factors. Hemophilia A, hemophilia B, hemophilia C. There are different forms of hemophilia, and these are different factors that are affected. When we're talking about factors, I'm talking about the things on the table. I think it was 17.2. Yeah, 17.3. This table right here, that's what they're talking about. So, for instance, hemophilia A, that is a deficiency in factor 8. So it is a deficiency. Was that 8 or was that 7? We have VII. Okay, yeah, we got 3 after the 5, so yeah, 8. Okay, that would be a deficiency in the anti-hemophilic factor, blah, blah, blah. Well, guess what? I'm still not changing what I said. On this table, I want you to know 1, 2, 3, 4, and down here at the bottom, 13. Is that? Yeah, 13. So what does this have to do with what we were just talking about with hemophilia? Just know that all of these chemicals are involved, and the different forms of hemophilia are caused by different problems in making one of these factors. All right. So what are the symptoms of hemophilia? You bleed a lot, especially into the joints. Treatments. We could inject tissue factors that have the chemicals we need. They prevent plasma transfusions and the risk of contracting hepatitis or HIV. All they're saying there is if you're having to constantly have new blood introduced every time you do, there's a risk. So if we can give people genetically engineered factors, we're not giving them whole blood. Thus, we're not giving them we're giving them these tissue factors instead of giving the risk of contracting a bloodborne pathogen. Okay, moving on. DIC, you remember, is if you have problems with both clotting and bleeding. So you get clots in the blood vessels that are not damaged, which can block flow. And then you have severe bleeding afterwards because the other blood is unable to clot because all the clotting factors have been used up. Septicemia, incompatible blood transfusions, complications of pregnancy. All right, we're going to be talking about the ABO blood typing here, because incompatible blood transfusions, that's a natural segue. I'm sure that's where we're going next. Before we do, I want you to understand that it's not just, a lot of people come through an anatomy class or biology class and like, oh, well, blood typing, it's the ABO blood typing. You're one of those, ABO. Sorry, A or AB or, yeah. Anyway, the ABO protein, that's one that we were about. And the other one, RH factor. Are you positive or negative for RH factor? Those are only two. There are more than 30 different blood typing mechanisms. And when we're going to get into it, we'll talk about the ABO, but understand that in a hospital, they're going to look at the maybe 6 or 7 different most common, most significant blood typing. And sure enough, the ABO, the RH, they're right on the top of that list. They're going to look at those. But they're going to look at others too. And even then, if they have the ability, they're going to take donor blood and recipient blood, put them together and smear them and look and see if they clot, if they coagulate, because they're not going to test for every single one individually when they can just do a test to say, oh, it clots or oh, it doesn't. Anyway, know that it's a lot more than just those two types. Anyway, so cardiovascular system will minimize the effect of blood loss by reducing the volume of affected blood vessels. You already know this means vasoconstriction. That's not just part of the vascular spasm with the clotting and the hemostasis. All the time we're doing vasoconstriction, vasodilation. The smooth muscle in the tunica media, the middle layer of the vessel, is either increasing how hard it contracts or relaxing a little bit to allow the blood vessel to get bigger. All right, so we can reduce the volume, we can make more red blood cells, but we can only compensate so much. If we lose enough blood, we're going to have problems. We need to fix that, and transfusions, giving people outside blood, is a method. If you lose 15 to 30% of your blood, you're going to be weak, your skin's going to get more pale. If you lose more than 30%, you're probably going to go into hypovolumetric shock, where your volume of blood is too low. If it gets way too low, you will cut off the flow to other things to send flow to the brain. Death from shock can happen if your volume goes too low. You have to fix the volume right away if that's happening. One thing to do is, here, normal saline or a Ringer solution, you inject fluid just to increase the volume. Yes, that means your red blood cells will be too diluted. All the good things in the plasma will be too diluted, but at least you will have the volume for the heart to keep pumping. This will restore adequate circulation, but it doesn't replace the oxygen carrying capabilities of the red blood cells. Whole blood transfusions are used when blood loss is rapid, and there's a whole bunch of it. The infusions of packed red blood cells are used for, like, say we infused a lot of Ringers or saline and we got the volume up, but it didn't have enough red blood cells, like we were just saying, then you could put packed red blood cells in. That's the PRBC. You transfuse in just the red blood cells. That's not too hard to do because when you see like at a blood bank, they've separated the blood out. You have the packed and then you have the plasma. They can take the plasma away and then put in the red blood cells. Blood banks separate blood into components. Shelf life is about 35 days. Human blood groups, if donated, must be determined because transfusions can kill you. Blood typing determines the groups. We already said there are obviously the two famous ones, the ABO typing, which gives you either I'm type A blood, or I'm type AB blood, or I'm type B blood, or I'm type O blood. That's all one protein, different alleles, different versions of the gene that make it, because slightly different shapes of the proteins. And we'll get into that. But the other one is the RH, the rhesus factor. It's another protein. It has multiple forms, but if you have any of them, we would say you are positive. If you don't have it, that means you have an allele, a version of the gene that doesn't work, and so you don't make any of those. No RH factor, we say you are RH negative. So if you hear someone is A negative, that means they have the A version of the ABO protein, and they do not have an RH protein in any form. Okay, so human blood groups. We might as well talk here about antigens and antibodies. I'm going to give you some definitions that are real simple. An antibody is part of your body. It is part of your body's immune system. An antibody is the part of the immune system. We're talking about little immunoglobulin proteins that float around looking for things that they think don't belong. They grab onto them and they call white blood cells. Big macrophage comes over and eats the thing. So I always compare an antibody to like a hunter-seeker probe that you send out looking for the thing to find it. Okay, great. An antigen, like is in boldface on the slide, is something that can generate an immune response. An antigen is something that probably does not belong in your body. So say we have a bacteria that gets into your body, and there are surface proteins on it that are unique, that are bacterial, and those are antigens. Those are things that could generate an immune response. An antibody sees the antigen and says, hey, this doesn't belong, come and kill that. All right, so you understand antigens and antibodies. Red blood cells on the surface have molecules, just on the plasma membrane, just like the bacteria I talked about. All cells do. An antigen is something that could generate an immune response if it looks foreign. Okay. So red blood cell antigens are also called agglutinogens because they could cause agglutination to happen. They could cause clotting to happen. Basically, that's how how they would fight. So, sorry, that's how the body would fight. If you put in a bunch of red blood cells and body's like, I don't think those belong. Those look foreign. It will then try to collect them up into little clots to prevent them from going out and doing mayhem in the body. So then you have clots that are formed. Anyway, mismatched blood transfusions. This blood that you're giving to try and save someone's life might look foreign, and then the body will agglutinate it, collect it into little clots, and destroy it. And that process could kill you. A couple different ways, but one, you could spill out a bunch of hemoglobin that clogs up the filtration in the kidneys. Right, nasty. All right, so there we go. Humans have at least 30 naturally occurring red blood cell antigens. I'm so happy that they're saying this in an accurate manner. So we have more than 30 of these different things, but we're going to focus on two that everybody does. So the presence or absence of each antigen is used to classify people into groups, bloods into groups. Some blood groups, M&S, Duffy, Kells, Lewis, are weak agglutinogens. And those are ones that if someone's doing a single transfusion, we're probably not going to check for. But ABO and RH, huge, super powerful, cause the most vigorous transfusion problems. So those are the major groups that we type when we talk about blood typing. ABO blood groups, I already told you, are based on different versions of the ABO protein. So, and there are two versions here, A and B. They are the same gene, same protein, but slightly different shapes. What is O? O is another allele, another version of the gene. Allele just means version of gene. So you have an A allele, A version of this gene, that's going to cause you to make the A protein if you have it. You have a B allele, a B version of the gene that'll cause you to make the B form of the protein if you have it. And then you have an O allele. What's that? Oh, we don't see anything. It's an inactive version of the gene. The O allele doesn't tells you don't make that, so you don't make a protein. It's not functional. Now you can have combinations of these things because you have two copies: copy from dad, copy from mom. Since you have, if you get a copy from dad that says make A and you get a copy from mom that says make A, then your blood type will be A. If you get a copy of A from dad and a copy of B from mom, then the A tells you make A, and you do. You put A proteins on the surface of the red blood cell. But the B says, but make B, and you do. So you put B proteins on the surface of the red blood cell. And that means that the red blood cell has both A and B proteins on the surface. We would call that type AB. And if you get a copy from dad that says, I don't make any proteins, and you get a copy from mom that says, I don't make any proteins, then you're going to have type O. Great. All right, so that's O has neither A or B antigens. I really just like them using agglutinogens. I understand they're antigens that can cause agglutination, cause clotting, but they should just stick to antigens. It's hard enough. All right, so blood may contain preformed anti-A or anti-B antibodies. So agglutinins. What these things do is attack something that looks foreign. So if someone has type B blood and you give them type B blood, that looks normal to them. But if you give them type A blood, that has the A antigen on the surface. That's not normal for their body. They might have antibodies that are anti-A that go around looking for things that don't belong, like A, and then attack all the red blood cells that have A on the surface that you've transfused in. Anyway, so act against transfused red blood cells with ABO antigens not present on the recipient's red blood cells. Yeah, so if it doesn't look like your own cells, you're gonna attack. Anti-A or anti-B can be formed in the blood at 2 months of age, reaching adult levels at 8 to 10 years of age. Okay, great. So here we have pictures of they have A's as little spikes and B's as little circles. And you can see that the antibodies will match the antigens. So if someone has B blood, they have the circles, the B. But they could also have anti-A antibodies. That means they have these that you can see they're shaped to grab the little cones. If blood is found, blood is transfused in that has the little spikes, then like these little spikes, then they'll be attacked. Okay. Same thing if you are type A, you might have anti-B. You have the A protein on the surface, but in the blood plasma, you have the anti-B. Now, what's interesting here is type O. I already told you O is, oh, well, we don't have any. So if you got type O, you don't have the proteins on the surface. You can see there are no antigens on the surface here. No spikes, no circles. That means that type O are really valuable for blood donors because they don't have some of the same things on the surface that could cause problems. If we're only worrying about ABO, we're not worrying about the RH, which we should worry about. But if we're combining ourselves, the stuff here on table 17.4, where they're not talking about positives and negatives for the RH, this type O could be given to A because there's no B on it that looks weird, or it could be given to B because there's no A on the surface that looks weird, or it could be given to AB because there's nothing on the surface that looks weird. So that means O blood can be given to O, to A, to B, to AB. Yeah, great. But if you give a type O person A blood, their blood plasma has antibodies that will attack the infused cells. If you give them B, they've got things that will attack. If you give them AB, they have both things ready to attack. So the practical upshot is that type O can only take O, but type A, type B, type AB, those can all take O or what they have. Actually, and then AB is just like O is a universal donor. O is a universal donor. Type AB is a universal recipient. Because it has A on the surface, there are no antibodies against A in the blood plasma. I'm saying these purple things. Because it has type B proteins on the surface, there are no antibodies against B. I'm talking about these green things here. So type AB could take any of these. Type O can only take O. Moving on. All right, so now we're talking about the positives and the negatives. Remember, I told you RH for rhesus protein. There are 52 different types of RH proteins. C, D, and E are the most common. In Americans, 85% of Americans are RH positive. So if you are, what that means is that the majority of the people, we would say, oh, they have A blood, they're A positive, or oh, they have B type blood, they're B positive. This RH is just another protein that could be present on the surface, and usually is. Anti-RH antibodies don't form spontaneously in people who are RH negative. Anti-RH will form if an individual receives RH positive blood or an RH mom is carrying an RH negative mom is carrying an RH positive fetus. The second exposure to positive will result in a transfusion reaction. What we're saying here is be honest with your doctor. If you are pregnant and they say, have you ever been pregnant before? They need to know, because they need to be able to prevent a transfusion problem. If you are RH negative and your baby is RH positive, and you don't tell them you were pregnant before with a baby that was RH positive, there's a chance that some doctors might not. In reality, we have enough medical knowledge now that they should, oh, you're negative, here, take this, we'll give you shots. But if they don't, then they don't, then it depends on if you're telling the truth or not. Your body may be attacking the blood of your child during the entire pregnancy. It could be horrible. Oh, and there it is. It's on the next slide. Hemolytic disease of the newborn, also called erythroblast fetalis, occurs in an RH negative mom with an RH positive fetus. The first time you're pregnant, when the baby is born or miscarried or aborted, you're going to tear the placenta. We'll talk more about the placenta at the end of this class, but placenta has mommy blood and baby blood, and the two come close to each other, but they do not mix. They are separated from one another until you tear the placenta. When you do, those bloods can mix. And so if you have an RH negative mom, she's exposed to, if you have an RH negative mom, and if the baby is RH positive, when the placenta is torn, that blood is going to mix, and her body will say, that doesn't look normal, and she'll make a bunch of antibodies against it. And the next time you're pregnant, if the baby is RH positive again, she's going to be making anti-A antibodies. How do you say anti-A? Sorry. She'll be making anti-RH antibodies that will then be attacking the RH positive blood cells through the whole pregnancy. Those antibodies can cross the placenta, destroy the red blood cells of the positive baby, and baby treated with pre-birth transfusions and exchange transfusions after birth. That's how we would treat this. You also could give someone a shot of the RhoGAM serum containing anti-RH. It can prevent the RH negative mother from being sensitized. So we have that's why you have to be honest. Don't say, oh, no, I wasn't pregnant before. Tell them, yeah, you were pregnant before, and they'll give you a RhoGAM shot, and that shot will prevent you from attacking the body of your child, attacking the blood cells of your child. Okay. So what happens if we do a transfusion the wrong way? If we put mismatched blood into someone's body? The donated blood is going to be attacked because of the antigens on the surface of the red blood cells. This will cause the blood cells to agglutinate, form little clots, and those clots can clog small blood vessels. Those cells, as they start to be eaten by white blood cells, those little clots, they'll rupture, they'll release hemoglobin into the bloodstream. You're not going to be able to carry as much oxygen because you're blocking tissues. You are not going to deliver blood beyond the plug or the block. And the hemoglobin, it can cause renal failure when it hits the kidneys. Probably from clogging up the glomerulus. But anyway, moving on. So what are the reactions like, the symptoms? People get fever, chills, low blood pressure, their heart's working crazy. Why? Trying to get blood to all the tissues. You can have nausea, vomiting. How do you do this? Prevent kidney damage with fluids and diuretics to wash that plugged up hemoglobin out. donate a lot of type O blood to dilute the bad stuff that you gave. And let's see, type AB universal recipient, misleading other agglutinogens, transfusion reactions must also be considered. Yeah, like the RH. Okay, autologous transfusions. The patient will donate their own blood that's stored and used if needed. This is a real common thing. I have a family friend who, when he went into surgery, for months before he knew it was going to be a major surgery that was coming up, months before, he went in and donated his own blood for the surgery. So when it came time to do the surgery and they were having to give him several units of blood, it was his own blood they were giving him back. And that's what the fancy autologous transfusions refers to, is transfusing someone's own blood back in. All right, so blood typing. The donor blood is mixed with antibodies against common agglutinogens, blah, blah. Oh, yeah. If gluten is present, clumping will occur. What we're talking about is, let's go back to, do they have a pretty picture? Yeah, they do. Oh, that's a great picture. I love that they're doing the real thing. Okay. So if you look right here, if it says, let's start with the two easiest ones. We got type O blood. Okay, type O blood, no agglutinogens, doesn't agglutinate with either A or B, with either serum. So we put down an anti-A sera, we put down an anti-B sera, we put a drop of blood in both. You can see we're not forming any clots in the A, we're not forming any clots in the B. This blood, this type O, it's fine. We know it's type O, we're not clotting. If we're testing a blood to see what is this blood, and we put a drop of anti-A sera, a drop of anti-B sera, a drop of the blood to test, a drop of the blood to test. We stir it up, and on the anti-A side, it stays smooth and fine. But on the B side, it forms distinct. You can totally see them clumps and clots. Well, that tells you that the anti-B sera has detected the B antigen on the surface of the cells. If we do the same thing with A blood, the anti-A will detect the A, and the anti-B will say, oh, there's no anti-B. If we take AB blood and we do the same thing, the anti-A sera will clot with that blood because there's A present, and the anti-B will clot with that blood because there's B present. Okay. Blood is typed for ABO and RH in the same manner. Cross-matching between specific donor, specific recipient. You mix the recipient serum with donor's red blood cells, mix recipient's red blood cells with donor serum. If all of that goes smoothly and you end up with no clumping, no clotting, yeah, just transfuse. Okay, diagnostic blood tests. If you examine blood, you can learn things about people's health. If you have low hematocrit, low levels of hemoglobin, remember, that's anemia. Blood glucose tests can check for diabetes. Leukocytosis can signal an infection. What they're saying is if you got a lot of white blood cells, that's what that says, it'll tell you, oh, you have an infection. But you can go further than that. We have what we call a differential white blood cell count, and it'll tell you, oh, well, you have a lot of eosinophils. And immediately, like, there's a parasitic worm problem going on here. Before you've even found the worm, before you've seen them, you can tell that your body is trying to fight like it's a parasitic worm. So, microscopic examination of the blood can reveal any variations in shape, size, or color of red blood cells. And we would do that when we're looking for things like anemia. Okay. Okay, why did I pause there? Stop a second. And okay, yeah, we are right at the end. Here we go. So that was on the next slide. Where I was talking about the differential white blood cell count, you'll see it. So microscopic examination of the blood, you can see variations in shape, abnormal size, color, shape, indicate anemia. That could also be abnormal shape. The first initial indicator you might have something like a leukemia, white blood cell cancer. All right, anyway, differential white blood cell count looks at the proportions. That's what I was talking about when I said, oh, they're eosinophils, it's a parasitic worm. Or, oh, there are a lot of neutrophils, probably a bacteria. Anyway, you could also look at prothrombin time, platelet counts. Those will assess how well you would clot, hemostasis. You could do a comprehensive medical panel that checks all sorts of blood chemical levels. If you have problems, you could have a kidney or liver disease. A complete blood cell count will look at all the formed elements and the hematocrit, which of course is hemoglobin level. Developmental aspects of blood. Fetal blood cells form in the yolk sac, the liver, and the spleen. Obviously, in adults, that's going to be in bone marrow. But red bone marrow is primarily hematopoietic by the 7th month. Okay, so before birth. Red blood cells develop from mesenchymal cells that we call blood islands. They will migrate into the bone. The fetus will form hemoglobin F, which is better at picking up O2 than hemoglobin A, formed after birth. You might remember we've talked before about sickle cell. One of the things that they can do to help treat sickle cell is give people chemicals that induce hemoglobin F formation. So, like, I'm an adult now. I don't make that fetal hemoglobin, but I wish I did because that doesn't sickle like the hemoglobin I have does. So we turned hemoglobin F production back on, so at least some of the patient's hemoglobin is not affected, not sickling. And it's also better at picking up oxygen. Let's see. So blood diseases of aging, chronic leukemias, anemias, blood clotting disorders. These things are paired with, we see them along with people who have problems with hearts, problem with blood vessels, problems with their immune system. Getting old sucks. And that is the end of this chapter. So let's stop it. And